want to welcome you to the USC Dialogue Series, Road to the White House 2012. For those of you who are new to the series, this is a joint effort, and it's by the Dornsife Jesse M. Unruh Institute of Politics, the Annenberg Center on Communications, Leadership, and Policy, and the School of Policy, Planning, and Development's Judith and John Bedrosian Center on Governance and the Public Enterprise, and I'm Dan Mazmanian, Director of the Bedrosian Center. Today, we're going to have, I think, a rather informative and hopefully challenging presentation and discussion about healthcare reform 210 and what it really does imply for the road to the White House for our presidential candidates upcoming. And I have the privilege of introducing our panelists. I want to start with Amit, Pabla, Amit, raise your hand, right here. Pursuing a master's in healthcare administration in the School of Policy, Planning, and Development with specializations in health systems operations, ambulatory care, and ancillary services. Amit is currently working on projects to increase access to healthcare via telehealth and telemedicine at the Veterans Administration Long Beach Healthcare System. Susan Land, is currently pursuing her master's in health administration with a certificate in management of ambulatory care systems. She received her bachelor's degree at the University of California, San Diego with a biology major and psychology minor. In addition to being a student, she's completing her administrative residency at Children's Hospital Los Angeles in the quality department. We're asking Mike Nichols to lead off in presenting the material. He received his PhD in none other than the School of Policy, Planning, and Development and his master's degree from the University of Oregon. Prior to his doctorate, he served as Associate Director and Executive Director of a regional health planning organization. Mike serves on several journal editorial boards, as well as the boards of several healthcare policy and research organizations. He comes very well prepared to, I think, engage and answer your questions about these issues. Currently, he is an associate professor of clinical pharmacy and pharmaceutical economics and policy in the School of Pharmacy here at USC, with a joint appointment in the Andrews School of Gerontology and the School of Policy, Planning, and Development, and chairs the university's Health Collaborative. Finally, Mike's experts in health policy, health economics, healthcare costs, and resource utilization. So with that, I'm going to introduce Mike, let's make a presentation, then we're going to go to Q&A. Mike, the floor is yours. Thanks.
Oh, good afternoon, everybody. This is a great room. I haven't been in this room before. I really like this a lot. It gives us an opportunity to actually see each other all the way through. What I'm going to talk about today is an issue that I think is going to be very important through the election, and it's one where we really have some problems associated with the information that voters have and the way that voters have integrated. So the quandary that we've got now is that voters care about the problems of health insurance. And I'm going to show you some data associated with that where it is clear that they think that this is one of the major issues that's facing the country today. But voters are very confused about the provisions of healthcare reform in 2010. And I'm going to illustrate a couple of those particular issues about the way that they integrate the material around healthcare reform and the health system. The other part that is a real problem for policymakers is that voters are very willing to embrace conflicting views. In other words, they may want a they may be willing to say that they will not adopt a policy that will achieve that outcome. And finally, voters really are not very well informed with regard to the alternatives. And I'll tell you that about some of that's not their fault, because some of the alternatives really have not been adequately addressed. Now, throughout the presentation, by the way, I've appropriated some of the slides that have been developed through the Kaiser Family Foundation. They do a health tracking poll. It is an outstanding site if you really want to be able to see what's going on with regard to some of the health reform issues, as well as the way that voters perceive health reform. KFF.org, and then they've got a whole series of slides. So I've pulled a few of them that I think will be very pertinent for this particular discussion. So this is and I'm going to alternate between some different time periods and in which they actually implemented the tracking poll so that you can see how people have changed or not changed over time. So this particular slide was done in June of 2011. And when they look at the major issues that are confronting them and the things that they want to hear more about within the context of the election process, economy and jobs drives everything. Big surprise there. But notice the magnitude associated with healthcare. It is the next biggest topic as far as voters are concerned. At 26% of the voters expect to hear something around healthcare. Even the deficit, war issues, immigration, all of those are dramatically lower in terms of their particular interest. So then if we go back to a part of the tracking poll in 2008, one of the questions was, do you favor or oppose federal government doing more to help provide health insurance for more Americans? Pretty resounding yes associated with that, with 75% of the individuals saying yes, we favor that the federal government should be doing more in this particular area. Only 21% oppose, and then a small proportion just don't know. So clearly we're starting to see that there's been a real interest today and also a very strong interest about the time that some of the proposals related to healthcare reform were going on. So some of you that might not be all that familiar with the issues around health policy and particularly the issues on health insurance, I thought it would be useful for us to talk about three major concepts that people care about. And the reason why we care about these is because they are frequently in conflict. Those three issues are access, quality, and cost. Now, there's a very famous restaurant in the Midwest that says, you know, you can have good food, fast food, cheap food. Pick two out of the three. Because you can't have all three of them together, okay? We got the same situation going on in terms of healthcare within the United States. We can increase access, we can increase quality, but please don't ask to have a cost lowered in that kind of a frame. So we've got to be able to trade off the types of goals that we might have in each of these areas. Now, one of the things that I'm going to tell you as we go through this process is that voters really don't understand some of the issues about health reform. I don't have time to go into that. Obviously, this was a very complicated bill, nearly 2,000 pages. At your right there at the table is kind of a one-page cheat sheet around 2010 reform focused on cost, quality, and access. And so you start to get an idea about what the elements are of the reform bill in each of these areas. And we could spend a lot of time talking about what each of those individual components mean, but at least I want you to be aware of the types of policies that were incorporated within the 2010 reform, because we're not going to have time to go through those in a lot of detail. But now let's think about it from the standpoint of some different alternatives that we might consider. Different alternatives that were actually encouraged within the context of the reform bill. So again, we're going back to a 2008 time frame here. This was the health tracking poll that they did in September of 2008. Said, how many of these registered voters favor tax breaks to businesses as a way to expand coverage, to expand Medicaid, to expand Medicare, tax credits to individuals, employers pay or play, so either they provide health insurance from the employer's perspective or else they have to be penalized within the tax code, individual mandate, and single government plan. You notice that we've got strong preferences around everything except for the single government plan. That was the only one that did not have a majority of, again, these are registered voters who were supportive of it. Now, the problem, though, comes in when we start to think about it within the context of, okay, it's great to say you want all these things, but what's the most preferred option? What's the solution that we think that we're going to be able to live with? You notice that actually there is no most preferred option from the standpoint of this set of registered voters. Almost equally distributed around the potential options associated with this. Now, what I will tell you is that from the standpoint, as you'll see on the sheet that's in front of you, the tax breaks to businesses, the expanding Medicaid, expanding Medicare, tax credits for folks, employers pay or play, and individual mandate were all incorporated within the context of the 2010 health reform. One of the things that's important for you to realize, you've probably seen some of this already, because there are provisions within health reform that came into place immediately. One of those is the extension of the COBRA benefits out to individuals who are 26. Very big, important issue. Also, some of the things that have come into place fairly quickly are things like elimination of maximum lifetime limits on health insurance plans, and also, as you can see, requiring individual insurers to be able to cover pre-existing conditions. So some of those things happen fairly quickly. There are a variety of other issues that happen over time, particularly as you notice the employer and individual mandates are scheduled to slot in 2014. So it's not immediate. It's going to happen over a period of time. Also, the provisions around health insurance exchanges. And that's a very complicated process, and so there is time necessary to be able to build that. We're not going to have a huge amount of time to talk about health insurance exchanges, but that is one of the key elements of this particular revision. Okay, so one of the real problems that we've got here, all of these kinds of preferences that voters were talking about before pretty much got wrapped up into the 2010 reform. But they've got a relatively negative perception associated with that particular bill. And so it's almost like we've got this reverse situation where if you look at the individual components, they're very positive. The whole, they're very negative. So let's look at some of those issues around that, particularly as they look at it from the standpoint of the impact of the reform on themselves, as well as the impact on the country as a whole. Voters are confused, and I'll show you on this tracking poll where they basically admit to that. And then also voters don't understand the effects of the changes. In fact, they think that some of the changes didn't actually occur when they did. So that's a real problem. So again, this is a tracking poll that Kaiser Family Foundation uses. So one of the things that they've been able to do is month by month track how individuals perceive whether or not they're going to be better off, worse off, or about the same under the provisions of this particular health reform. Notice that nothing's really changed. You've got the same basic level of understanding about whether or not they're going to be better off or worse off throughout that entire time period from 2010 through 2011. There's also no real agreement about whether or not the country is going to benefit through this particular process. Look at the fact that you've got somewhere in the neighborhood of about 20% of the people that say, it's not going to make much difference, and then a split on the remainder about whether or not the country is going to be better off or worse off. And it just hasn't changed very much during this entire time period. Now who's responsible for that particular issue? Got to lay this one directly at the feet of the Obama administration. The Obama administration has not been very effective about communicating what some of these revisions are and what the impact of these revisions are likely to be. Now, this is one of the things that strikes me as very interesting too, as we start to look at how they perceive this and whether or not some of the revisions that they were really interested in actually occurred. Are they favorable about the health reform bill, or are they unfavorable, or maybe uncommitted? And as you can see, we've got about 40% that are favorable, 40% that are unfavorable, and about 20% haven't got a clue. So those kinds of divides make it really difficult for policymakers, and you can tell that's going to make it very difficult for the electorate to be able to come up to some kind of an understanding about this and make a decision when you talk about presidential politics. Some of the concerns, I would argue, may be related to their lack of knowledge of the law. And again, this comes back to exactly how much information they've got and whether or not the administration's been really clear about it. I think that one of the frequently held opinions is that the uninsured are dominated by the unemployed. that the only folks that don't really have health insurance are the folks that don't have jobs? In fact, the folks that don't have jobs have good health insurance. They've got Medicaid. They have access to health insurance. The folks that are employed, where they've got employers, large employers like University of Southern California, you have a high proportion of individuals that are employed in those types of corporations that have health insurance coverage as well. The folks that don't have health insurance coverage tend to be young. They tend to also be in wage positions where they're basically not at a high income level, and their employers don't extend job offers. So out of the 50 million folks that were uninsured in about 2008 or 2009, fully about 15 to 20 million of those individuals are working people that don't have access to insurance some other way. That's really important to think of when you're trying to build a health reform to be able to expand access. The one that I don't have in here, how many of you think that health reform covered illegal immigrants? Okay, now wait a minute here. Nobody thought that it covered illegal immigrants? Okay, thanks, Dan. Thanks, I needed something like that.
You mean I'm wrong?
You're wrong. Illegal immigrants were specifically excluded from the bill. And those constitute somewhere in the neighborhood of about 5 million of the 50 million that are uninsured, somewhere right around that particular component. That's not to say that they won't get health insurance, they won't get health coverage. They will go to the emergency room just like everybody else that doesn't have health insurance. But in this case, it's clear that the beliefs about where we need to make changes with regard to access to health insurance is incorrect. The voters generally don't understand who the folks are that don't have access to health insurance. Here's a direct example where they don't understand one of the provisions of the law that's gone into place in 2011. I'm going to read you a list of specific reform proposals and tell me whether or not it was included in the health reform law. Among the 52% who say that either they or someone in their household has a pre-existing condition, you can see that 60% of them say, yes, the insurance companies are going to be prohibited from denying coverage for a pre-existing condition. But you've got 46% of them that say, no, the insurance companies are still going to be able to prohibit that. That's a huge problem. This is one of the major tenets of the health reform and one of the issues that people have been concerned about for a long time. When you've got nearly half of the people not understanding that that actually was one of the major components of the bill, you got a problem. Now, here's where we start to see what the problem is. Fully half of these individuals in April of 2010 said that they didn't have a clue about the information in the health reform law that's going to impact them personally. And notice that we've got it still at 52%. In March of 2011. My guess is that that hasn't changed very well. Actually, I'm going to show you a trend on that too. You start to take it a step further and ask whether or not it describes their own feelings about health reform. Confused, anxious, angry, enthusiastic. More than half of the individuals are saying that they're just confused about the health reform bill. And again, that hasn't changed over time. It's been relatively constant as we look after the actual adoption of the bill. Okay, now here's the issue that the Obama administration has got a huge issue with. There's little change in how Americans expect the law to affect their health care. So under this particular reform, will your ability to get and keep health insurance improve? About a third of the individuals said that in April 2010 after the law had been signed. About 26% are now saying in March of 2011 that they think that they will be better off. The cost of health care for you and your family, 25% said they're going to be better off. 23% in March 2011 say they're going to be better off. The quality of your own health care, 23% better, 20% better in March of 2011. Notice that you've got large proportions that say that they think they're going to be worse off in those last two areas, cost and quality. That's a huge problem.
A quick question. I think you told us this was of voters.
Yes.
Do you have any comparables for non-voters?
The Kaiser Family Foundation,
currently not being covered?
they don't really show that in terms of the folks that are not registered voters. And again, part of that's because this is a tracking poll that is related to the public policy process. So if they look at it too, half expect access for the uninsured to get better, but fewer think the same about consumer protections, quality, or cost for the nation. If you look at this again, those blue ones there on the left-hand side are still relatively small, except for that excess for the uninsured. And that presents a real problem if you're part of the administration that was responsible for seeing this reform passed. If we think back, remember those basic areas that we were talking about in 2008 that they wanted? Notice that the majority want to keep major elements of the law except for the individual mandate. As you go down through that, they still have the same level of fervor about those key components like tax credits to small business, in this case closing the Medicare drug coverage donut hole, guaranteed issue, which is basically that you will be able to get health insurance if you have pre-existing conditions. Financial help for low and moderate income, increased Medicare payroll tax on the wealthy. All of those are 58% or above. But when you get to the individual mandate, you got 27% of the individuals that say keep it, and the rest say let's not. However, if you look at the individual mandate, there is some malleability. In other words, it's possible to inform them of the implications associated with doing away with the individual mandate, and they may change their minds related to that. So again, you've got 67% of this particular group that said let's repeal it, but once you start talking about it from the standpoint of most Americans would still get coverage through their employers, so nothing's going to change from that standpoint, and that they would satisfy the individual mandate requirement without having to buy any new insurance, would you say that they should repeal this part of the law? 55% of them say, no, okay, under those conditions, we're not going to repeal it. We don't think it should be repealed. Well, that's actually what is within the law. Now, without such a requirement, people may wait until they are seriously ill to buy health insurance, which will drive up health care costs for everyone. Would you still say lawmakers should repeal this part of the law? Half of the folks say that they should repeal it. So that means that they really don't understand the fact that if we don't have that, the resources have to come from someplace, and guess what? It's going to be us kids. It's going to be the folks that have insurance, where there's going to be cost shifting that goes on, and there's also going to be taxpayers that are going to pick it up through the different types of Medicare and Medicaid components. So then the next question is, well, could we substitute a state plan for the federal plan? And in this case, the voters say yes. 2/3 of them say we should permit states to go ahead and substitute their own plan. And then when they asked them about that, they said, would you still favor the idea if some states decided to save money by providing more limited insurance to fewer people than the National Health Reform Law? All of a sudden that changes. So they said, no, we're not interested in that. We want to be able to maintain the level of benefit around the particular individuals, as well as the level of that particular benefits. So then the next question is, well, if we're going to repeal the law, if we're going to do away with it, what are the alternatives that might be out there? Now, one of them obviously is related to a single payer plan, and we're just going to touch on that in a very limited way, because we've got some really strong partisan perspectives on the favorability of the law. Big surprise, right? Partisanship in this particular environment, you're really surprised about that. Everybody's shocked. Voters actually do understand, though, that alternatives have not yet been proposed. So we're essentially looking at the reform law versus something else yet to be described. And notice the partisan disagreement. It is profound. Where you look at Democrats and the percent who have a favorable opinion of the law, it's come down some. You've had about from anywhere around 78 to 72%. Now it's closer to 60 to 65%. The independents are pretty much at the same level that they were. And then the Republicans are very dissatisfied with the issues in the health reform law. When you ask registered voters about whether or not the Republicans have actually proposed some type of an alternative, you notice that virtually every sector understands that the Republicans have not proposed an alternative. Even the Republicans, you've only got 23% of them that say, yes, we think that there's an alternative on the table. There's also no agreement on whether the Republican reform proposals would be preferable. So if you think about it from the standpoint of whether or not the Republican proposal would lower the amount the nation as a whole spends on health care, 25% of the electorate says we think the Republicans would do a better job. If we look at protecting consumers in the private health insurance market, about the same proportion. Lowering the amount you and your family pay for care or covering the uninsured are both right at about 20%. So there's an understanding that there's going to be a relatively small proportion that think that the Republicans are going to be able to do a better job. So what are the alternatives that we've got? And to be honest, as I was preparing for this presentation, I started to check out a couple of 3 different things. Well, there is one website that is the GOP Pledge. And I don't know if any of you have accessed that, but that's a really good way to look at whether or not you've got particular alternatives, not just on healthcare, but a whole variety of sectors of the economy. So at this stage, the stated Republican alternative, this is on their site, medical liability reform, allow purchase of health insurance across state lines, expand health savings accounts, which are the ones that you can set pre-tax dollars aside. At this stage of the game, limited to about $5,000. They want to expand it out to about $15,000. Ensure access for patients with pre-existing conditions, and permanently prohibit taxpayer funding of abortion. So obviously we're talking about some key components associated with this, but obviously not as sweeping as some of the other areas. Now, the other thing though is that those of us that have been involved in health policy for a while have seen a variety of areas where you kind of get an idea about where the Republicans want to go. And the first thing is that they've been, Mark Pauly, who's a health economist out of the Wharton School, proposed 10 years ago that it's important for us to decouple employer-based health insurance. We need to be able to take it out of the situation where the employer is providing a subsidy and make it so that the individual makes that determination. The view being that if you pay more of your health insurance, you're going to be a much better buyer with that. You won't be asking for more than what you actually need. Eliminating the tax break for health insurance. This is a huge tax break right now. All of the employer contributions and your contributions for premiums come in a tax break. It's all done in pre-tax dollars. And so essentially if that is coming in post-tax dollars, it's going to increase the cost associated with health insurance by, on average, somewhere around 25%. There is the discussion about a possible tax credit for health insurance for the poor, those folks that might be employed but not eligible for Medicaid. But at this stage of the game, we're really not clear how these particular proposals may affect access, cost, and quality. So again, in conclusion, we've got health reform as a priority area. Voters don't understand the key provisions of health reform of 2010. Voters embrace inconsistent views regarding what they want and what they're willing to fund. And it's not clear whether or not they're going to demand specific alternatives to the existing reform to be able to evaluate presidential candidates as we go into the race for the White House in the future. So with that, what I'd like to do is come down. We've got some great panelists, and we'll have an opportunity for them to ask some questions, and we can talk about it, and then for you to ask questions as well.
That's great, Mike. Thank you very much. You said you found it difficult, but you really did give us a whirlwind look.
That was a quick tour.
A quick tour, but really I think has laid the grounds for some interesting challenges and questions, challenges to the issues and questions. And where do you want to start? Should we start down here?
Yes. My first question is, how can health care be made more affordable without limiting access to necessary care?
You got to understand, these were basically prompted questions. Okay, so
Mike.
It's all right. The principal issue that we've got to deal with is something that's going to be in between what we see with the Republicans and the Democrats. Any way we cut it, we're all going to have more skin in the game. We're going to have to pay more for our health care. At this stage of the game, the problem is that we essentially get relatively low-cost health insurance, which then says we should continue to demand more. And if we're demanding absolutely appropriate care, that's one thing. If, on the other hand, we're asking for more than what we actually need, we've got a bigger problem.
All right, next question.
Into the mic.
Oh, sorry. How does the rise in costs affect efforts to expand coverage to the nation's 47 million uninsured individuals?
All right, these are the really good master students, because one of the things that happens when you think about the individual mandate and trying to bring more people into the system so that they're going to pay premiums, and we take out things like lifetime limits, pre-existing conditions, we're essentially starting to cover more people at a higher cost. Who are the people that are going to be interested in the lifetime limits and the pre-existing conditions? Not the healthy people. It's the sick people that are going to be more expensive. If we've got those additional costs, we've got to have something in terms of additional revenue. Otherwise, what's going to happen is it's going to end up with much higher premiums for folks that are insured. And that's one of the reasons why they looked at individual mandates as something that was really key. You may have seen the Republican debate, what was it, 2 weeks ago, where there was this interchange between Mitt Romney and Newt Gingrich about the problems associated with individual mandate, and where Mitt Romney said, we got the idea from you. And that's one of the things that a lot of people also don't understand. If you're on the liberal side of the mark, this is a bad thing. If you're more centrist, it's kind of a good thing. This reform is actually very, very similar to the 1983 reform proposed by the Republican Senator Bob Dole. And it stays within the context of our existing system, our existing market system, and they had to figure out a way to get additional revenue. Individual mandate. Tried to keep the cost of the premiums down. I think this is actually going to be a huge issue. We've already seen large increases in health insurance costs and premiums this year because of some of these provisions. The issue that, again, this is a question from a societal standpoint. I was at a panel this last Saturday where a insurer said that the inclusion of mandatory birth control, family planning, prevention, in all of the insurance plans is going to cost somewhere in the neighborhood of about $1 per patient per month. That's huge. That is a big increase. Again, right thing to do, but we've got to figure out a way how we're going to be able to keep those kinds of costs lower. I think it's going to have a big impact. Okay,
so going back to the issue of mandates, there are questions regarding whether or not mandates are constitutional. Mm-hmm. And so do you see the mandate as being unconstitutional or just another tax imposed by the government to those that decide not to have health coverage?
I think the big issue, and you may have been following some of this in the media, the big issue is whether or not there is the likelihood that they might separate out individual mandate as being unconstitutional so that the rest of the law stays in place. I'm not a legal scholar, so I'm not going to be able to comment much about that. It would be unusual for them to say that the whole law is unconstitutional because of that single provision. But again, from what it looks like at this stage of the game, the judges that have made the decisions around this cut down on really partisan lines. If they had been appointed by a Republican administration, they tend to want to get rid of the whole law. If they were appointed by a Democratic administration, just get rid of that particular provision. So it's going to be a really interesting issue. The ultimate problem is that if we don't have something around this type of individual mandate, we're going to have some real problems in terms of cost.
Mike, if you don't mind if I just take the prerogative of the moderator
Absolutely.
here. Just a question. How many here in this room would take out what will be relatively expensive insurance premiums if you are not required to do so? That is, if it's your choice, will you take out a premium to support this? Please raise your hand. Yes. Assuming your age right now and your health status, if you are not required to take out what will be a relatively expensive healthcare insurance premium in 2013, would you do it if you weren't forced to, compelled to by law? You would. I saw 2 hands go up.
3, 4.
Good.
Here we go.
I see 4 hands go up.
Bring the insurers in now. Bring in the insurers. Here's the.
I'm just trying to give a reality check of what many Americans are thinking to themselves right now in the face of this. It sounds like we used to use the phrase voodoo economics. You're adding 48 million people, you're increasing premiums, you're increasing service, you're guaranteeing lifetime, and it's not going to be more expensive. I like that.
Yeah. Well, what's interesting too, people don't realize what the effect, what the penalty is associated with if you didn't get your mandated coverage. The penalty would be about $2,000 on your taxes in 1 year. Guess what? That's about what your co-insurance is if you're in a major employer. USC, for example, the employers cover 80% of the premiums, and you as an employee cover 20%. Well, that's $2,000 is pretty much about 20% of single individual coverage.
Okay. What is your opinion on the federal government having too big of a role in the healthcare industry? Do you feel states should have the option of providing similar coverage? Yeah,
this is a real quandary because we've already seen that there are some quite different value streams. And I think the governors are actually kind of worried about this because it is very possible that if you've got a state that has more generous coverage requirements, that you would get an in-migration of folks that might be sicker. And again, that would drive up health insurance premium costs. We saw this, actually, it was really interesting. Howard Dean, who is governor in Vermont, when they adopted a mandatory insurance process, said that they needed to do it in a very careful way so that they did not end up in a situation where they were more attractive than Connecticut and New Hampshire, where people would then make that kind of migration. So this kind of a state option starts to become a really delicate dance related to your neighbors. The other thing that is really key is you've had a situation where all healthcare is local. So at one sense you say, yeah, it makes sense to do it from a state level perspective, but the financing has been predominantly national. 50% of the financing of healthcare comes from Medicare and Medicaid, which is federal.
Could we now turn to some questions from the audience? We'll come back, but any questions? I see hands going up. Introduce yourself, please, and fire away.
Hi, Stephen Hubbard, SPPD, program. One of the things I see as a continuing failure in all of this is the inability to address the cost side. So you can keep coming up, trying to come up with all sorts of alternatives of how you pay for what we've got. But when you compare the cost of our system to the other industrial states, we offer the worst care for the most. And from what I've been able to see, the cost will go up from somewhere between 30 to 50% in the next 5 or 6 years. And I've yet to hear a decent argument as to what is causing costs to continually go up beyond the cost of inflation. Is there anyone who's working on this with enough numbers? Because I don't think you can have an honest policy debate if you don't know what's pushing the cost.
There are a lot of people that are working around this particular issue, and the increasing cost has a tendency to be focused on a couple of things. One is technology. We have access to technology in the United States that other developed countries do not. And I'll give you just one real tangible example. If you have multiple sclerosis and you're in the United Kingdom, you do not have access to any of the more recent multiple sclerosis drugs. Because they have a single payer plan, they've got a budget, they have to make a determination about new technologies, about whether or not they're going to actually adopt them. And what they've done through a governmental process of assessing the effect of the medications is they've said they don't really have any effect. They're not efficacious. If you did that in the United States, you'd be reading headlines around it. And so we have access to technology that others don't have. There was a great frontline done by PBS about 6-8 months ago. Some guy who had the job I want traveled around the country, around all the developing countries, and visited with some of the folks in those health systems and said, let's investigate why we're so expensive in the United States and we don't get much out of it compared to where you are. Well, he goes to Japan, and starts talking with some of the folks that are involved in imaging and says, wait a minute, why does an MRI cost $3,000 in the United States and it costs $300 in Japan? And the individual who is a physician said, because we use 3-4 generations back. We don't use the most current generation. And so consequently, we get it at a real discount. We also tend to run it 22 hours a day so that you may be doing your MRI at midnight. Americans usually don't like that lack of convenience either. But so they've done some different things where they still provide access, but they don't necessarily provide the access to the latest and greatest. The other area where we've got some real issues is with regard to transitions. It's the handoffs between different components of the healthcare delivery system where a good deal of inefficiency comes in. So, for example, physician calls for an MRI, and then it gets read by a radiologist. The transmission of that information to the general practitioner is not nearly as good as it should be. We're hoping that electronic medical records is going to be able to provide some of that, but I'm still convinced that we're going to have problems there. The health reform bill, by the way, incorporated something called accountable care organizations, which calls for mandating quality assessment and monitoring as you go through the entire system, all the way from hospitalization to ambulatory care, long-term care. Each of these components are you're going to be accountable for the process associated with that. That's their hope, to be able to save some money around that. And then the third area is we tend to do much more intensive types of things. We tend to pay our specialists a lot more than we pay our primary care folks, and we also tend to not take advantage of physician extenders, for example, nurse practitioners, physician's assistants, who really have been demonstrated to be able to take care of a fair amount of everyday issues at a lower cost. So we're kind of upside down around some of those areas.
Before we're going to, Susan, Amit, do you want to comment on this also? Any thoughts come to mind? And into the mic.
I just agree with the last part. I know recently at the VA we've been trying to increase the scope of each of the nurse practitioners and the PAs.
What's a PA?
The PA is a physician assistant. A lot of the daily checkups, a lot of when patients come in, when they have a cough or anything, we use the PAs and the nurse practitioners to kind of weed out the patients, so those that really need to be seen by the primary care physician or by a specialist can see them, and those that can be sent home with maybe like a prescription drug or over-the-counter medicine, they can go home. So hopefully, I know by working at the VA, I'm a little biased, but I feel like we're really innovative with implementing new methods to decrease costs, and with Dr. Nichol's last point, it's really helped us so far.
And going back to what Dr. Nichol said about technology, I mean, we want the latest and the greatest. You know, we want the best iPhones, we want like the biggest cars, but the question is, like, the problem is that we want everything, but we don't want to pay for it. And I think that's one of the biggest issues in healthcare today.
So several questions, but one over here.
My name's Rosalind. I work at the Gether Institute, and it seems to me that healthcare agents are incentivized to deny coverage to people. And I think, you know, as far as customer service goes, that's a real quandary. But I think that's a larger issue of meeting a bottom line, and so I'm wondering what is inherently wrong with making a healthcare in and of itself something that is marketable versus something that's more of a rights issue.
The restriction that you're talking about is taken care of within the healthcare reform. And actually, the only way you can do this is by demanding it of every insurance company, so that it is a level playing field. That's what they're really concerned about. Now, in terms of that broader question, I should kick that to Susan and Amit.
Good, really tough one sit out of the right here. I mean, I think what you said was, why should healthcare, it's a question, be a right versus a good or a service you purchase in the marketplace? That was your question?
I mean, essentially, yeah.
All right.
Well, I would actually have to agree with you. It is a little controversial, but there are two sides of it. Is healthcare a right? Should everyone have access to healthcare even if they can't afford it? The thing is, the quality of healthcare in the United States, it's so high. Like Susan said, we demand the best. But should the best be free? And I mean, I think in other countries they would say no, because the amount of quality we provide, the technology we provide, should it be free or should it not be? And it's the American culture. We want the best, and at the same time, we want everyone to have it.
So are you saying there should be a floor rather than a ceiling?
Okay, I'll go into that. Yes, I think you got to have a floor, because one of the things that happens is that if there is no disincentive associated with your using more and better, you will use more and better. If you'll buy me a Ferrari, I will drive a Ferrari. Okay, I promise you. I would love to have. Oh, come on, no, I want one of those nice new red ones. I really do. So we will consume as much as somebody else will pay for. And that is the real problem that we've got within the United States. So what a lot of these other countries have done, I mean, the examples that I was using, they've said, we'll pay for up to this much. And if you want to get something else, you're open to do that. One of the things that happened about, I think it was about 7 or 8 years ago, the Supreme Court of Canada and also whatever the Supreme Court of the UK, I'm really revealing my ignorance, both said that it was legal for private insurers to offer a supplemental plan in those two places where you've got single payers. And it's really intriguing that as I've talked with some of my colleagues around those two countries, they've said the issue about waiting for service has kind of gone away. Because they've been incentivized to be able to do some of it within the context of some of these private facilities, and they basically have exerted a lot of pressure on the public facilities to get people in faster because you've got these two comparative systems that are going simultaneously. But again, folks that are buying the supplemental insurance are paying more to be able to get quicker access and maybe more access. And I mean, again, the bad news here, folks, is if we don't think we've got a two-level system in the United States in 2011, we're fooling ourselves. If you're going to go to, if you are poor and you have to go over to county hospital, don't be surprised if you're going to be waiting in line for 6 to 8 hours. If you have private insurer, you're not going to be waiting in line for 6 to 8 hours. So you've got two levels. The question is, how should those levels, be equilibrated?
I saw a question up here. Okay.
Graduate Student School of Education. You guys were talking about this need to have the latest and greatest technology and this pressure to purchase this latest and greatest technology. But is this data driven? Are we looking at other nations and seeing that, oh, well, maybe this nation has greater life expectancy, lower infant mortality rate, their people are generally healthier, they have lower rates of fatal diseases and such. If we're not at the very top of the list, and I know we're not, why is there such a pressure to purchase all this latest and greatest technology and try to utilize it if other nations are doing it better than us and they're using technology that's 3 and 4 years old?
Great question. All healthcare is also episodic. Do you think about healthcare every day? I'll bet none of you think of healthcare every day. I'll bet you only think about healthcare when you need it, right? And when you need it, what do you want? I want it done now, right? I want you to solve my problem, give me the magic pill, give me the magic image. I want to walk out of here feeling less anxious about what's going on with my illness. And I think what's happened for those countries that have a single budget is that they know they've got to make these kinds of trade-offs. So that they say, we will get you the service that you need when you need it, but you might be waiting for it a little bit, or you might be getting a different level of technology. And that is that becomes a real issue, though, from the standpoint of a political process, too. And they've got a culture where they're much more willing to do that. I mean, if you think about it from the standpoint of transportation in Europe, I don't have the stats on this. My colleagues at School of Policy Planning and Development, I'm sure, do. That culture is much more willing to use public transportation because they know that the cost of fuel is really high in their environment, that they import it all, and they tax it. I was in the UK this last summer, and if you look, I actually spent some time in Scotland. Do you know what the price of gas is in Scotland, automobile? It's about $10 a gallon. The cost for them to provide it, they actually are an energy-rich nation. So they actually have lower transaction costs on oil than we do because they can provide all of their oil. It's all tax. And it's specifically intended to change your behavior around the way you use your oil and gas. So they have a culture where they, as a society, have made those kinds of changes. And unfortunately, to some degree, fortunately, we have actually had the capacity up until now to be able to let people make those kinds of decisions on their own. And I think what's going to happen as we move forward is that there will be financial disincentives put in place. And I think that's going to drive a lot of it.
Mike, I'm not sure this is relevant, but it's about this question. Not my field, but I recall Oregon actually had, maybe still has, a comparable public process for allocating. How's that working out, and why aren't we hearing about it?
Yeah, actually, I was when you were talking about the public policy agency that I directed, it was the Western Oregon Health Systems Agency, and we were responsible for the public hearings around Oregon health decisions, which was put in place by John Kitzhaber, who, interestingly enough, was an emergency room physician down in Douglas County. And the reason why he introduced this process is he said, Oregon Medicaid is a rationing system. So they do what they can until they run out of money. And consequently, what happens is that if you've got kids that need immunization in September, October, November, December, they may not have the resources available to be able to do that, but somehow or other they've got the resources available to be able to do very expensive things like transplants. And so that was the whole process that they wanted to put in place. There's a whole lot of research around what happened relative to the presentation of cost-effectiveness information and how they set the stage related to the threshold on that. It was an intriguing process. They haven't really implemented it moving out because, again, they had to do that through a waiver process from the federal government on Medicaid.
See another question. Any others? We'll come back here. Go ahead.
This is more of a political question. With election law being that corporations can basically fund however much they want to a candidate, do you see drug companies playing an integral role in election 2012?
Interesting question. Okay, so I spent a lot of time. I still have a primary appointment in pharmaceutical economics. I do cost-effectiveness analyses around drugs and also cost-effectiveness analyses around different other types of healthcare interventions. So I've had a lot of interaction with many of the drug companies. What has happened with big pharma in the United States over the last 5 years is that a lot of the money that they had access to has gone away. The big blockbusters that provide a lot of their revenue have, by and large, been discovered. Many of these are going off patent. For example, Lipitor, which provides somewhere in the neighborhood of about 60% of the net profits for Pfizer, is going off patent within the year. That's a big deal. So it's going to be fairly difficult for them to get engaged around this. That having been said, they will certainly be an important contributor. They've been involved in the political process all along. All of the health insurers will be big contributors, I am sure. It's where the money is.
It's where the money is. Yes. And you are?
Petrie from the Other Institute. I also had a political question in the sense that right now the GOP debate is widely around Obamacare. After the Republicans choose their candidate after the primary, how do you see President Barack Obama talking about healthcare on his side? Is he going to be defending the healthcare reform bill, or do you see him trying to avoid the debate?
What he should have done over the last year is talk about the specific provisions that people wanted, and I think that's what he's going to do. He's going to come out and say, wait a minute, you guys all said you wanted this, 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 and this. We got it for you. And the individual mandate issue, he's going to have to be able to explain that we've got to have additional resources coming into the system, or else we're going to run into some real problems on funding. That's going to be a very difficult dance. That part's going to be a difficult dance for him because, as you saw, most people have just almost a visceral negative response to individual mandate. But I think it's also, I think what he will be doing too is pressing the presidential candidate on the Republican side to actually put on the table, because the one that we just talked about, if they actually do some of these things, it will definitely suck money out of the healthcare system. And if that occurs, people are going to have to understand how it's going to impact them individually. And I think that it will accelerate the amount of money that you've got to be able to put into the system. And it's going to be won't be said as a personal tax, but you're going to see the differences from a tax standpoint.
Let's see, last question here.
It seems like Obama's healthcare thing is pretty much going to go up to the Supreme Court now for them to rule on it.
Right.
So I think they're ruling on it before. Did they announce when? It's like around 2012.
Yeah, yeah. See, the real controversy is whether or not the Justice Department within the Obama administration pushes to have it considered by the Supreme Court prior to the election. I hope he does. I really think that that is the only thing that is fair to the nation as a whole, as you're starting to consider what the implications are on health reform. But that's going to be a decision that he makes.
Oh, sorry, I think.
No, go ahead.
If it ends up like them ruling against the individual mandate as unconstitutional, where do you see Obama going from there?
You know, the issue then is going to be, all right, let's sit down and try and determine what the impact is then going to be with regard to the resources that we're going to have. There are a variety of ways that you can put in an alternative. For example, what they did when Part D came up is they basically, which was coverage for drugs for the elderly. If you didn't enroll when it immediately became available, they had a penalty phase associated with it. And the real key problem here, think about this, if there isn't something like that, when would you sign up? You're incentivized not to sign up until you really need it. And then all of a sudden you got a huge amount of costs that might come into it. So what they did with Part D is they said, you don't have to sign up, but eventually you're going to have to pick up your premiums. And so that's one of the alternatives that they could have thought about as they were putting together the health reform law. And that might be one of the things that they propose.
Well, I'll tell you, we've come to the end of our hour, and I'm sure we all feel more educated.
And a lot happier too, probably, right?
And ambiguous, actually. Ambiguous in terms of where we think this should go as individuals. And the show of hands earlier, or the absence of hands, suggests to me that this is going to be a tough sell to the American people. You're talking about a younger audience.
An educated audience.
That is going to be asked to pay.
Yes.
And for the goods for the good services that's provided to others.
Yep.
It's a challenge in any policy area, particularly this one. But with that, please join me in thanking Amit, Susan, and Mike for joining us.